Hi, this is going to be a lecture on Mast Cell Activation Syndrome, or MCAS. And you may have seen patients coming into your office inquiring about this as a chief complaint. There's a lot of information on the internet about this, and a lot of it gets blown out of proportion or misunderstood by patients. So this lecture will help you understand and dispel myths and educate your patients. I have nothing to disclose for this lecture series, and I must acknowledge and give credit to Dr. Leonard Weinstock, who is one of the presenters at the 2021 LDN International Conference that was held here in the US. And these slides are essentially from his lecture on MCAS. Let's briefly discuss the basics of Mast Cell Activation Syndrome. And this information comes from Moldering's in a critical review oncology and hematology journal from 2015. So MCAS may be congenital. A lot of times we don't think about it as such. And there is an epigenetic component to this which induces somatic mutations in some but not all of the mast cell progenitor cells. Now the progenitor cells originate in the bone marrow, and then they sort of migrate to other tissues. Aberrant mast cells are few at birth but do increase with age. Rarely is this condition serious in infancy and childhood, and it often can resolve, but it tends to worsen with teenage and adolescent years and into adulthood. Aberrant mast cells are instigators to the mast cell activation syndrome, yet remain less in numbers. Mediators of aberrant mast cells activate healthy mast cells, and their mediators do the same for neighboring mast cells. So it sort of spreads, and it can affect the other mast cells in connection and contact with them. The mediators of healthy mast cells are the main inducers of the symptoms. This is a description and a cartoon about what's going on with mast cell activity in MCAS. You see aberrant release of mediators, you see a number of receptors and T-cell microparticles that activate mast cells, and of course the B cells that produce the antibodies. You have things like antigens, you have degranulation that occurs, and histamine release. You see the input for IgE and IgG, probably amongst others. So with MCAS, there are over 1,000 mediators. That's an incredible number. The general categories of these mediators are histamine, proteases such as tryptase, we'll talk about that in following slides, heparin, pro-inflammatory cytokines like tumor necrosis factor alpha and others, vascular permeability and dilators, leukotrienes, platelet aggregation factors, and antimicrobials. Again, there's probably many more, too many to list here. So how does MCAS present clinically? Well, often the onset is in folks that are 20 years or younger, and it sometimes can go unrecognized for decades. It tends to be multisystemic, often of inflammatory presentation in nature. It is quite perplexing because it is inconsistent in its course. Abnormalities often are externally apparent. There's this chronicity and chronic waxing and waning, and it's very episodic. Different symptoms at different times, and often there are no obvious triggers. And you'll see patients that have been to many, many doctors with many different diagnoses and misdiagnoses, and then at one point or another, usually in their 20s to 30s, patients will commonly stop reporting these symptoms because it makes them look like they're crazy. They often get to 3 or 4 physicians and then after that, they're being referred to psychiatry because this is considered a psychiatric disorder in what they're describing. Much as you see with Lyme or MCEDs, a lot of physicians are usually involved before a definitive diagnosis is made, and patients usually get tossed around with all kinds of idiopathic syndromes being diagnosed for them, or frank just misdiagnoses. So MCAS suffers the same situation where patients can get frustrated. There are some systemic syndrome that we'll kind of discuss here, constitutional being that of fatigue, fever, either weight loss or weight gain. You have central nervous system presentations such as headaches, migraine-like headaches, brain fog, panic attacks, anxiety, depression, and insomnia. The esophagus can be one of the organs that are seen to be affected in large numbers of patients with GERD, dysphagia, chest pains. There are stomach issues, nausea, dyspepsia, and lower GI effects such as bloating, abdominal pain, both constipation and diarrhea. And then you see sometimes liver enzymes increase. And overall, a large number of folks will have an immune problem. You'll see poor healing and the inability to fight off a whole host of infections, from viruses to bacteria to parasites to things like Lyme. If we look at MCAS symptoms as a percentile, you'll see larger numbers of folks complaining about fatigue, muscle pain, syncope or presyncopal episodes, headaches, itching, urticaria and hives, nausea, chills, edema, eye irritations, dyspnea, and heartburn. MCAS is a clinical diagnosis because the serology testing and other tests are sort of not as reliable as we wish. So it's important to ask your patients some very important questions. Ask them if there's any symptoms of anaphylaxis. This can clue you into MCAS. Also, how do they react with regards to insect bites? Do they swell up with gnat bites or no-see-ums? Are they super sensitive to mosquito bites with high histamine release when in contact with or bitten by insects? Sensitivities to odors, or sort of like a sick building syndrome where people have heavy sensitivity to smells and odors and fragrances, headaches, nausea, fainting may ensue. Tinnitus has been shown to be present in about 60% of folks with MCAS, and also bloating. SIBO in about 30%. You'll see spontaneous bloating, which is a mediator phenomena. And then restless leg syndrome appears to be present in about 40% of folks with MCAS. So how do you make the diagnosis? Well, it's mostly clinical, and there's some consensus, and this was from an article by Valent in 2019. So you have severe recurrent mast cell symptoms. Oftentimes this is anaphylaxis, and it has to involve 2 or more organs, including things like urticarial flares, flushing, pruritus, angioedema, nasal congestion, wheezing, throat swelling, hoarseness, headaches, hypotensive episodes, including that of pre-syncope and syncope, tachycardia, cramping, and diarrhea. With an increase in mediators, you can look at preferably tryptase or an increased tryptase activity from baseline with 2 attacks. Less specific mediators like histamine, NMH, prostaglandins, and heparin can also be used, but again, they are not as strong as we hope for them somewhat like your Western blot in trying to diagnose Lyme disease. And then thirdly, you can look for a response in a mast cell directed treatment plan with medications to see if the challenge with these medications or herbals will actually help with symptoms. And then you can say, well, you've got a diagnosis if it's helping. So some of the most overt signs of MCAS are changes to the skin, and you can see that as urticaria or hives. You have pruritus without rash, so just itching but no lesions. There can be flushing, atypical acne. You can see bruising and telangiectasias, fibromas, and lipomas even in certain cases. Other manifestations on the skin are hemangiomas and red nevi, either flat or raised, usually presenting on the trunk or abdomen. And it's very difficult if you're doing a Zoom encounter because it's hard for patients to place the camera close enough and zoom in on these lesions. So sometimes in-person encounters are required. So for MCAS workup, there is some laboratory that can be done. However, it's pretty low yield. So I've listed a few here. Prostaglandin D2 and histamine, maybe the more sensitive. Heparin analysis, you need an ultrasensitive laboratory, and apparently there's one in New Jersey and also one in Germany that does this. But again, these are kind of low yield. Even lower is tryptase, and if you do get it and it's greatly elevated, then it can make you think of other things, including some neoplasms. So be careful with this. But again, I typically will rely on my clinical observational and history taking skills versus serology in cases of making a diagnosis. And I grab a hold of the challenge aggressively. So I'll challenge people with therapies and see if it helps with resolution and make a diagnosis based on that. So let's talk about some triggers. You'll see dietary triggers, so food allergies and sensitivities. You'll see infections such as tick-borne infections, mold, Epstein-Barr, CMV, HHV6. So a viral burden can actually make this worse. I suspect also chemicals and heavy metals are triggers. Dysbiosis due to overuse of antibiotics. SIBO, stress, both physical and emotional stress, abnormalities and imbalances in hormones, and you can also see this manifest during pregnancy, electrical or environmental stimuli like EMR or EMF with the smart meters that some people cannot tolerate, and it manifests as MCAS. And then autoimmune, such as reactions to vaccines. So you can see manifestations, as mentioned earlier, with skin manifestations and some of the symptoms and signs, but it also can lead to POTS and also hereditary Ehlers-Danlos syndrome. So folks that have hyperflexibility, double jointedness, skin that's really elastic, they can sometimes also be much more affected. So the big tenets or rules for MCAS treatment is you definitely want to identify and avoid triggers. That's the first thing. You don't want to keep adding fuel to the fire there. You want to also block receptors of the mediators. You want to inhibit mediator production, and you also want to inhibit mediator release. And we'll talk about some of the therapies here in a minute. So part one of treating MCAS, you want to avoid and identify some of the triggers. So food elimination, you can use elimination diets, 3 to 4 weeks. Sometimes it takes longer, 6 to 8 weeks, sometimes 9 weeks. Gluten, dairy, yeast, histamine. So gluten is number one, followed distantly by dairy, which is number two as far as food allergies. You can also pull the trigger very quickly on doing some food allergy testing to back it up because elimination diets are very cumbersome and difficult for some patients. Once you've identified food sensitivities and food allergies by eliminating them through a proper protocol, you may find that this actually helps to avoid flare-ups. Also avoiding stress, emotional or physical stress. You can have folks do yoga, meditation, mindfulness meditation, guided meditation, things like that. Even daydreaming, getting away from the laptop or the cell phone for a bit. You can also investigate the different drugs that they're taking, and especially excipients that are in those medications can be things like fillers, food color, things like that that may also cause problems. Also remember some medications actually have gluten in them, so be careful with prescribing medications for folks sensitive to gluten. Odors and electrical impulses or electromagnetic fields should be investigated. Vibrational triggers, hormonal triggers, and atmospheric triggers such as changes in barometric pressures. Well, we can talk about first, second, third, and fourth line treatment, but the first line treatment steps are the most important. As mentioned before, avoidance of triggers is paramount. That's stress, alcohol, heat, cold, etc. Dietary interventions, first line, avoidance of gluten, dairy, yeast. Prescribe a low histamine diet. Don't be afraid to do food allergy testing. Then you can look at H1 blockers. So your kind of first line classic histamine blockers, and there's some listed here, and also second generation for less drowsiness and less side effects. You can also look at H2 blockers. They are sometimes used in conjunction with H1 blockers or sometimes as standalones for effectiveness. Again, first line considerations, leukotriene blockers, and then remember also the comorbid conditions to treat POTS and EDS, Ehlers-Danlos syndrome. So don't forget that those things may have to be treated as well. You can also look at more natural things for mast cell stabilization, and that's quercetin and luteolin. Those are both natural occurring substances that can be used to treat this condition. Cromolyn can also be used as a second line mast cell stabilizer, but it tends to be fairly expensive. And then you've got your second generation H1 blockers like ketotifen that can be administered orally. We use that to treat pretty significant leaky gut and SIBO conditions. And then, of course, lastly are what we call the fourth line treatments, are monoclonal antibodies such as Xolair. But I'm not a big fan of monoclonal antibody therapy or biologics because of all the side effects and the collateral damage you can occur. So I would typically start off with some of the natural things like quercetin or luteolin as first line for me, and then bring in some H1 and H2 blockers. Dr. Weinstock at the LDN Conference did present a study that he did with some efficacy in the use of LDN. So low-dose naltrexone is another therapeutic that can be used with some efficacy and proven results. In this study, Dr. Weinstock used approximately 116 subjects, so it was an N of 116, and he noted that there was some improvement in about 60% of those subjects. In about 28% of those on LDN for MCAS, there was no help. In other words, it failed. And then because of side effects that led to discontinuation, That was about 22% that could not tolerate the LDN. Again, I'd like to thank and acknowledge Dr. Leonard Weinstock for the use of his slides in this presentation. And this presentation was made for the Priority Health Academy for teaching purposes of candidates and attendees. The Priority Health Academy is a nonprofit 501c3 nonprofit, non-government organization that's primary goal is to train advanced practitioners, that's nurse practitioners and PAs predominantly, and also educate some of our health coaches in the ways of functional medicine. We do offer sub-internships and preceptorships, so if you have any questions or want to reach me, my email address is listed here. I'd love to hear from you. Hope you enjoyed this presentation.